try to be punctual when I can. So we're gonna start here in just probably a minute. Full disclosure, I hate doing this. So thank you all for showing up and making me stare at like 50,000 faces. It is kind of fun though, I will say. So I often talk too fast and I often slur, so you can throw something at me, some peanuts. If you think I'm talking too fast, I'll stop and slow down. So, and I hope it might be kind of short, but I hope it's at least informational and a little bit fun. We do these talks every once in a while and we all get our little niche, I guess, and they asked me to do this one and it's pretty fun. So, bone health, I'm going to talk about bones in general, then we're going to move into osteoporosis is really probably the biggest problem that we face with bones, most common. So I'll go into osteoporosis, and then after that we'll have some questions, and probably have plenty of time. If I get too hungry, I'm just going to walk out and they'll hear questions. So just some fun facts about bones. I think that's just sort of fun, I guess. We're actually born with around 300 bones. And we actually get less bones as you get older, which is kind of cool because they fuse. So a lot of when we're babies, we have lots of different plates in our head, they fuse. So we actually end up with 206 bones. And 51% of those are in our hands and feet. Which kind of makes sense to me because when you see the pictures, you get all kinds of bones, but hands and feet are more than half. Kind of goes without saying, but bones hold us up. They protect our organs, our ribs, protect our heart, protect our lungs. Of course, our cranium protects our brain. They also allow movement. Obviously, our muscles have to have something to attach to move. Collagen is the most prevalent protein in your bones, and it's constantly replenishing. We actually get, this is the coolest, I think. We have a new skeleton every 7 years, which is kind of neat to think about. Even though you guys may be Medicare age, your bones still turn over. So you actually get a new skeleton. It's pretty interesting. And that plays a part in the medicines way at the end of this talk, kind of how the medicines work. Your bones don't just stay the same. So the medicines can work on the turnover. And then I think this is neat. We have one floating bone in medical school. This is just a fun thing. Every other bone, muscles and stuff attached. This one floats. It's right here. Right above our voice box. So like the tongue and stuff attach a little bit to it, but that's just a floating bone. Kind of neat. Does not attach to any other bone. A little bit about the anatomy. The inside of the bones is the bone marrow. You guys have probably heard about that. People get bone marrow biopsies where you go right in here. So the center is much more spongy. It's full of red blood cells, white blood cells, helps fight infection. So when you have a fracture, you get a lot of swelling because there's a lot of blood inside bones, and it will bleed. So collagen, like we said before, that's that protein. It's like a framework, like a scaffolding. And the calcium is what fills in the scaffolding. That's why we need calcium for healthy bones. And that's kind of a simplified way, but that's really the easy structure. Up here, this is just a little fun. Smallest bone in the body, way up here, in your ear. There's actually a question on golf. Thank you. I had just done my research, and so I got that question right when we were golfing. But it is very tiny. It's like millimeters. And that helps us here. So the bone turnover, we have something, in med school this is kind of hard to memorize. I always thought osteoblasts versus osteoclasts. I hate it when they have just too close of a word. Some of you, my patients may have heard me talk about the poopers and the Pac-Men. That's why I have a picture of poop right there. Osteoblasts lay down bone. So in the bone turnover, you've got some cells, and literally they poop the bone out. That's how I think of it. They poop it out, and then you have other ones like a Pac-Man. They break down the bone. So that's how it constantly remodels. And we will have different osteoblast amounts, different amounts of osteoclasts during our lifetime. equal sometimes. You build the bone up. And that's what this is saying. Children and teens, obviously you're growing, but not only are they growing longer and bigger bone, they're actually, cartilage is turning into bone. They have much more turnover. Obviously larger, heavier as we get older. Young adulthood, it's about equal. It depends on the person, depends on genetics. You know, most people probably up until about 30, 35 are still forming their actual skeleton and forming the bone that they're gonna have. Some it's maybe a little earlier based on genetics. And then as we get older, menopause status, that really changes things. Bone turnover can depend on the hormones. If you have estrogen on board, we tend to still have stronger bone. We're still laying down some good bone. And then after menopause, we seem to be breaking it down a little bit more. And I had to fill up some time. So few diseases, obviously the bottom one, osteoporosis, we deal with that all the time. I think I see that every single day in clinic. Paget's disease is less known, and osteogenesis imperfecta, but they all deal with the same thing basically. Paget's disease, you have excessive osteoblast and osteoclast activity, so way too much, and it can be in one bone. So you might have your leg bone, the regulation is off. I'll show you a picture here shortly. And it can bend the bone, it makes bones much thicker. It's not formed correctly, so you get deformities, which actually is this. So Paget's disease, I mean, if you look at the finger here, you can definitely see that it's thicker, more white. We don't see this very often. I think I've had 1 or 2 patients in my whole lifetime have this. But this poor guy, if you look, you know, this leg is pretty normal. That leg is not, and under the microscope, or excuse me, under an x-ray, this is what it looks like. Very disorganized bone. For x-rays, you know, we like to see them they're white, but not this white. If they're really almost see-through, then we know you have osteoporosis on an x-ray. So the osteogenesis imperfecta, I've actually never had a patient with this. It's a genetic disorder. There are all kinds of degrees, and it is a very bad disease. Typically genetic from birth. They will most of the time know this. Nowadays, even before someone's born, they'll know this. Not enough collagen is made, so there's not enough of a scaffolding for the calcium to even go into. And depending upon what grade a person would have, they can fracture by doing nothing. You can pick up your baby and you fracture their ribs. I've heard of a few, in the olden days, there were reports of, you know, they think the kid is fine, then all of a sudden they're brought into the emergency room with all kinds of fractures and they blame the parents for abuse, and really it's not, it's this. Nowadays we're usually better at picking it up before that happens. But that would be this. Now, healthy bone on the left, brittle bone disease is what they call osteogenesis imperfecta. That's a pretty simplified version, but this is what can happen. So this is the thigh bone, literally is supposed to be straight. That was broken. That's broken. See how that's supposed to be straight? That's the thigh. This is the leg bone. Look what happened here. That was broken. That was broken. That is a fairly young child and they had that many fractures already, and they can just be running and bump the couch and have a fracture. So it's a bad disease. Thankfully we don't see it very often, but I thought it was interesting. Osteoporosis is the one we deal with and what most of this talk is going to be about. I thought this was kind of fun. If you remember the osteoblasts, they build you up. Osteoclasts, get rid of it. So it's usually balanced. Down here, osteoclasts say, screw that, I'm going to blow it up, and just, they chip away a lot more than what is built. Kind of like that other picture, this is normal bone. This is osteoporosis bone. Now this is not like necessarily even zoomed in very much, it's just as disorganized. So you have the density and the mass decrease. I will explain it in the clinic in my head. I like to be simple. I think of it as If you have osteoporosis, the 2x6s in your house on your walls are now 2x4s. They're just skinnier, and you can kind of see that here. You get little tiny pieces here rather than bigger, thick pieces. Not only are the 2x6s 2x4s, the structure's falling over. You know, I could have 2x4 walls and probably get away with it. But when your 2x4s are falling like somebody did here, that's a pretty pathetic bone, and whoever that was probably got fired. And so osteoporosis is pretty easy to diagnose. You guys have probably had a DEXA scan. A lot of you have. We actually have it here in Sibley. It's very simple. You just lay there. I think I have a picture coming up. That's the most common way. There is something called a FRAX score. A FRAX score is much more of a calculation. You can see here it estimates your 10-year probability of having a fracture. It's based on age, sex, weight, a few other things. But you kind of do have to have a bone test similar or get a DEXA scan in order to get the score. When we do our DEXA scans here at the hospital, I get a sheet, I look at the scores, all these little numbers, and I try to explain it to you guys. And we will get a FRAX score on there. It's kind of automatically calculated unless you're on treatment already. If you're brand new, not on anything for your bones, you get a FRAX score. So you might hear me talking about both. The DEXA scan looks something like this. You just lay there. It's real nice and easy. It's pretty comfortable. It takes just a minute or two. But DEXA, it's also kind of fun. It stands for Dual Energy X-ray Absorptiometry. That's why we say DEXA. It gives me, so typically you'll have your, on the bottom, your hips and spine. People break their hips and their spine more often than anything, especially postmenopausal. Those are the scores we get, and based on T-scores, we decide you have muscle bone, or you osteopenic, which is kind of an in-betweener, or you osteoporosis. I think my next slide goes into that. 65 and older is typically when we start getting the most DEXA scans. Medicare pays for them. It's recommended at 65 and older. Sometimes we'll do a little bit earlier, depending upon family history, if you've had other fractures or not. So this is osteopenia versus osteoporosis. I'll be honest, I'm not sure I have ever done, maybe a couple patients where I've done a bone density scan and they're completely normal. It doesn't happen. Grand majority of people are in osteopenia range. I had a bone density, for some reason in med school, they thought they were going to kill us or something, so we all had bone density scans. I don't know why, for free. Great bones, most all of us. By the time you're 40, 45, 50, that is not the case, probably osteopenic. But these T-scores that I often will explain to you guys, if you have a bone density scan, I get a cute little board, we'll go through it. T-score, it's like a number line when you're in grade school. Remember, like a big old X. The horizontal line is 0. Underneath that is -1, -2, -3. That's really the numbers we get. If you are -1 to -2.4, osteopenia, just kind of a precursor to osteoporosis. We like to try to treat you then, before you would get osteoporosis. Sometimes we don't catch it. Other times it's not covered by insurance. Medicare only covers one class of medicines I know of right now for osteopenia. If you don't qualify for that class of medicine, you just don't get treatment. Osteoporosis is different. They'll cover lots of meds for that, but you gotta be bad enough. So they want you to be bad before you can fix it. The thing about osteoporosis is, so -2.5 and under, so -2.6, -3, -3.5, that is a really bad number. So based also on how bad you are, you can qualify for different medications, and we'll go into that later. But it is a silent disease. You've probably heard of blood pressure. High blood pressure is a silent killer, yeah. Osteoporosis, we also forget, it doesn't really cause symptoms. Some people will say, well, I have pain in my bone. Do I have osteoporosis? It doesn't typically cause pain unless it causes a fracture. But it is so silent, you don't really know you have it until you get a fracture. That's why, thank goodness, we are allowed to screen for it. typically at 65 and over. And who gets it? You might hear me say this is one thing that the little skinny ladies get more than anybody else. One good thing about obesity is you actually have better bones because you're carrying weight around every day of your life. So Asians and white ladies, I always say my little skinny white ladies get worse bones. It does affect all races, but the Asians and the white typically are worse. You can have osteoporosis in men. It's much less common. If you do have it in a man, the white men are a little more prevalent than the rest. Men, I have a few male patients with osteoporosis. Typically they're on maybe chronic steroids for maybe their lungs, a different condition, prostate cancer. If people have prostate cancer and then they get the injections, they take away your testosterone. Just like we get our estrogen taken away, if they get their testosterone taken away, their bones can get worse too. Kind of already said this, but women age 65 and older, we are allowed to screen others based on the risk factors, and the risk factors is a few, and we are allowed to screen younger. The question also is it covered by insurance? And I'm probably not supposed to give an insurance talk, but being practical in the world, I would like to screen probably more people than I do, but then you have to either eat the cost or wait till you're 65. So risk factors, this is a weird little picture, but it really kind of made this easy for me. Risk factors, so that when you see people like this, doesn't mean they have osteoporosis, but they surely may. Alcohol use, if I go over here, alcohol use, corticosteroid use, that's steroids like I was saying. Not eating enough calcium. Estrogen is low, well that can be menopause, or we can take your estrogen away with some treatments that we do for cancer. Smokers have worse bones and a sedentary lifestyle. If you move more, use your muscles, the muscles pull on the bones, that will cause your bones to be stronger. This is in the younger people. Over here, hormone status, irregular menstrual cycles. So, a lot of you are moms, grandmas, whatever. If you have a teenage kid that's a runner, or maybe plays basketball, and they expend a lot of calories, and they're this skinny little thing that is always going, and they don't get their periods regularly, one of the main concerns of that is their bones. They're still laying down their bones for adulthood, even at the age of 18, 22, 25. If they don't have regular cycles, their bones can actually dwindle away, and they're set up for having fractures at 35, 45, 50, rather than 75, 80. So that's probably one of the biggest reasons we will try to address irregular periods. It's nice not have a period, but if you go too long without it, that's a problem later in life. Prevention. The osteopenia phase, honestly, most of us are in that now. So we would like to prevent it before we get to osteoporosis. So a good diet, we always think of calcium, but we also need protein, just a basic to get our magnesium and our phosphorus. We don't just have to get in the calcium. But vitamin D and calcium are still the most important. We don't eat probably a lot of fatty fish around here, some of you might. Egg yolks, we're always told to take your yolk out because bad cholesterol, right? So who eats liver anymore? I don't know. So vitamin D is actually kind of hard to get enough of, especially if you're on treatment for your bone density. It is hard to get enough vitamin D, so we also often say supplements. And the sunshine is a way to get it, but then they say put on your sunscreen. Then you don't get it, so it's like we're just can't get enough vitamin D. Calcium, of course, milk has it. We forget broccoli and dark leafy vegetables do have calcium in it, fair amount. And on these daily amounts here, the 600, 800, and 1,000, it depends who you talk to. Cardiologists don't like very much calcium, then they think you get calcified plaques. Rheumatologists, they love a lot of calcium. So it really depends who you talk to. I think family medicine, we're supposed to be the in-betweeners that make peace. So this is it's a range. So also to prevent, obviously since the risk factor would be smoking, if you stop smoking, that helps. Even avoiding secondhand smoke is important. Little alcohol, but most of the evidence says probably no alcohol if you're really gonna do the best for your bones. And of course, exercising. Walking is good, stairs, anything that really makes you, put your weight down harder, running. But if I see any of you running on the street, I might be concerned. So don't start running. But strength and resistance training has been proven some of the most effective for at least that osteopenic stage to help prevent you from getting to osteoporosis. Oh yeah. You don't have to look like this if you want to do some strength training. I have a lot of patients who, I don't want to get those big muscles. Well, good luck. I think it's pretty, actually, I'd like to do that, no problem. So strength training, I think a lot of people hear it and they go, ugh, I don't want to do that. But I think we don't always go about it the right way, and we could do strength training without getting huge muscles. One of the biggest important things to do to prevent osteoporosis, besides what we just went over there, is prevent some falls. If you have a fracture, you're going to find your osteoporosis, and we're going to look back and say, what could we have done that you didn't have a fall? These are some very, very obvious, but optimized vision, I think a lot of us care about your heart. You always go to the doctor for your heart, maybe you forget about your eyes. Or let me just push my cataracts out further, I don't want to do it yet. Maybe sometimes we shouldn't be pushing those out, because if you have a fall and you break a hip, that can be catastrophic.
Yes.
Avoid low blood pressure. We always think about high blood pressure, but sometimes if it's too low, you get up, you stand up to go get the TV remote, and by the time you take 2 steps, you're so dizzy and you fall over and you break something. Can we prevent that? Doctors' fault a lot of time is avoid polypharmacy, too many medications. If you go to 5 different specialists because you have heart problems, you have, diabetic problem, orthopedic problem, we're not always good at talking to each other or looking, and you get put on a med from this doctor, that doctor, ends up being a lot of medications, and sometimes they are needed, but sometimes we need to be a little more careful about that. And then the balance and coordination and strength, very, very important to prevent falls, to prevent fractures. Very practical things on the left side, just some things you maybe like outdoor-wise we can do better, indoor-wise we could do better. Obviously a cane or a walker, I know a lot of people don't want to use it. I hear that a lot. Put some racing stripes on them or something, you can make them cool. They're not that bad. Stop at curbs. Don't just, expect, like I'm talking to a friend and go up the curb, make sure you stop at the curb, look down and do it, and then go. It seems stupid, but curbs, I hate curbs. I think all doctors hate curbs. Shoes with deep treads. I think we might think they're really grippy and good, but they're too grippy sometimes. Deep treads can really get stuck on carpet. You can skip the toe there and then fall forward, something to think about. You can salt your sidewalks. I didn't know about kitty litter. Do people put kitty litter on the sidewalks? It's within this. It's interesting. In the wintertime, the bottom, most important to me, it's okay to skip church. When we're on call on the weekend and it's a little bit icy and it's Sunday morning, we pray that we won't have a sweet little lady that's going to church that breaks her hip because they have to go to church. It's okay. You can listen to church. That we do have a lot of, we have a lot of good habits, but I think sometimes if it's bad outside, don't feel bad. So do something like that. We also forget about pets. People love pets. I have had patients come in where the leash was wrapped around their ankles and they fell and they broke their hip. Love pets, but they can be very harmful sometimes. Try not to walk in socks at home, stockings. They can also not be grippy, you can slip and fall. Grab bars, electrical cords, we don't have any here. Where'd they go? And then more lighting. That might sound dumb, we all have a lot of lights in our house, but the switch might be over here. So very simple things. Sometimes maybe grab bars aren't maybe so simple, but get your kids to help you and get some things set up. Fall prevention. I thought this was applicable. If you've ever seen my mother paint, I've seen her do something like this before. Ask you. Here's the ladder right here. Yeah. And then there's the staircase. She's a woman. So medications, there are a fair amount of medications for osteoporosis. Really one class that's oral, some IV medicines, some shots. They can be approved for prevention, treatment, or both, but really the prevention would be in the osteopenia range before you get the osteoporosis. And there really only is one major class that's approved for that. Most of them, they work better with calcium and vitamin D supplementation. I always talk about the medications are like a carpenter and they need the building blocks to make it work. Calcium and vitamin D are our building blocks. So if your doctor puts you on a medication, they're very likely going to say you also have to take calcium and vitamin D. And then strength training, of course, is also important. If I'm taking a medicine for my bones and I'm doing calcium and vitamin D, but I'm sitting on my couch all day, my bones might get a little stronger, but they need the stress. They need those tendons to pull on the bones. I need to pick up even a gallon of milk. That really is weight. So some medications, believe it or not, estrogen is actually a medicine that more in the past they used to treat osteoporosis with. If we have a woman that's fairly young, let's say they went through menopause at 40, no longer have estrogen, and we know they have really bad bones and they're having hot flashes, we might actually treat their bones with estrogen because they also can treat their hot flashes at the same time. But it is not for everybody. There's a lot of risks with estrogen, so we don't do that one necessarily just for bones. The second group here, these estrogen-like, they're called SERMs, selective estrogen receptor modulator. It's very annoying. They act like estrogen on some tissue, like bone, but they have estrogen blocking effects on other tissues, like breast. It's a very interesting medication. Tamoxifen, maybe some of you have heard of that one. That's what that is. Not used very much with osteoporosis, but if you have other conditions, they might give you this medication to help the bones. Calcitonin, way on the bottom here. Not used very often. We use calcitonin probably most often if you fall and you have a compression fracture in your spine. So the boxes of your spine, one of the boxes fell. Calcitonin can help some of the pain. Actually, it's a nasal spray, very strange. And so that helps maybe more with the bone pain of a fracture than building the bone back, but it's okay to use. It's not very common to use, not very strong, but it's one of the last resorts. Then we get into, this is more of the big mainstream. These are the real treatments. Bisphosphonates. You maybe heard of alendronate. That's a once a week pill. This here, zoledronic acid, is called reclassed. It's an IV yearly infusion. This is the class that is approved for osteopenia, the precursor to osteoporosis. The pill is fairly cheap. You typically give it for a finite amount of time. You don't have to give it for the rest of your life. It's 3 to 5 years. Take a drug holiday, figure out if you want to be on nothing for a while. It slows down your bone loss. This is kind of the pooper and the Pac-Man. It helps you to decrease the Pac-Man eating up the bone and increase the poopers so you get more bone laid down. Biggest side effect is probably reflux. I see that in maybe 10 to 20% of my patients who take the oral form, and that probably, typically most patients say it just lasts the day they take it. So if you pick Saturday for your weekly treatment, they might have a little reflux, but that's literally 10 to 20% of my people, just what I see. Most people tolerate it very well. Parathyroid hormone analogs. This is all kind of fancy stuff. If you don't pay any attention to this, that's totally fine. Forteo and Timlos, I have used these a few times. Around here, for some reason, I don't know if they're covered as well as some of the other ones we use. It's for treatment of osteoporosis in those that are pretty high risk of fracture. It's a daily injection. I think that's probably why I haven't loved it, because who wants to inject themselves daily? It's kind of hard to get patients to want to do these, and they are fairly expensive. So I think the more common one is coming up here. This was kind of funny. I keep finding these all over the house. The doctor says bone loss is normal at my age. It's pretty good. I love her face.
Yeah.
The face. That was the best. So those daily injections, they're good, they're fine, they're not all that practical in my opinion, because if you're gonna tell me to shoot myself daily after my whole life, I've never had to, I don't know that I want to. It is very good for some people. We do around here probably push a little bit more for this medication, Prolia, because it's every 6-month injection, don't have to do it to yourself. I'm not trying to advertise one medicine over the other, but this is why in the clinic, if you hear me or my partner say things, this is kind of where it comes from. This is for pretty high risk people. We have a lot of you out there actually with pretty poor numbers and high risk. Every 6-month injection is awesome. You don't hardly have to think about it. Very low side effect, and it's safe for the kidneys. The one thing about the bisphosphonate class, the one that has the oral, we gotta watch your kidneys a little bit with that medication. Prolia is great and fine with kidneys. It's also fairly strong. The one under it, Avenity here, that's probably the strongest one that I know of. It treats very severe osteoporosis. That T-score number with the number line system, negative 2.5 is osteoporosis. Avenity, typically it's people in the negative 3.5 or lower range that get that. And then maybe you can qualify when you're negative 3 and under. But those are the people that really need some quick bone growth before they go fracture something. And honestly, they probably already have fractured. It is a monthly injection that you would get like at the hospital or clinic, monthly for 12 months. 12 months is because they basically have studied that for 12 months and they did a really amazing job in those first 12 months. They just stopped the study and they were done. So for now, that's a 12-month treatment. There are patients that will get Avenity for 12 months and then will jump to Prolia for maintenance to keep what they built. So kind of a little summary, because I didn't want to take too much of your time. Bones are living, they're always constantly building and breaking down, and that plays a part in medication later on, plays a part in what you do when you're young and as we get older. Diet and exercise does affect bone health. Low bone density, whether it's osteopenia or osteoporosis, is silent. You don't really know you have it. It's probably asymptomatic until you get a fracture. Many practical steps that we can do to reduce falls. They're practical, but we don't always listen to them, which is fine. I don't either. And reducing falls, I think we don't do enough of therapies. I can tell somebody to please go do this at home, but if you don't have the help, or sometimes people come into your house, the occupational therapist will come into your home and actually say, hey, you should get rid of that rug. Hey, maybe put a grab bar here. I don't think we do enough of that, and we probably should do more often. Also, physical therapy, they can help you with your balance, they can help you with your strengthening. So something that don't be afraid to remind us, actually, if you come and see us, remind us that, hey, can we do some physical therapy? That's great. And then osteoporosis is treatable, but it would be the best to catch it a little bit early and prevent it before you get too bad. Some boring references. This was my favorite. A little off color, but hey, that's a fun one to end on. Any questions? Any questions at all? I don't feel bad if there's none. Yes. Oh, you in the front.
Can you take calcium without vitamin D, or do you need to take those together?
You can take it without. We actually do vitamin D levels in some people. If your level is appropriate, you could take calcium without it. Most of the time though, they're gonna say to take vitamin D with it because we just don't typically get enough. Unless you're a huge milk drinker with vitamin D fortified, we don't get enough sun anymore. We don't eat the weird fish. We don't have a lot of egg yolks. So most of the time they will still say it, but you can take it without. Not a bad answer. Yes.
Of the two types of calcium you can take, one is suggested to take it with food and the other not.
Calcium is so good and bad. So calcium can constipate people. It can give you a little gut rot. So it depends on who you are. You know, you might get a pharmacist to say, take this calcium with food, take this without. To me, do not feel good. Because I have seen so many different ways and every patient seems like they're different. So I don't think anything is gospel when it comes to that. But I try to tell my patients, take too much calcium, you can get constipated, you can get kidney stones. There are bad things that you can get with too much calcium. I had one person one time, I think they were taking 8 tons a day, every single day, for their reflux. They had kidney stones and they can have some bad stuff too. So you don't want to just go home and eat a ton of calcium.
What about arthritis?
Arthritis and, yeah. Arthritis is hard. There's not a lot to do for arthritis except don't get old. And that's hard. Some people say, you know, oh, I have arthritis, I should not exercise. You should. The best thing to do, in my opinion, is stay active as you get older. Because when you lose it, you truly lose it. If you don't move it, it goes, and you get arthritic and you can't move. I actually think some patients do the best when they, you know, you got your routine of weightlifting, you have your routine of walking, keep doing that. Literally, I've had people go in the hospital for a totally separate issue, 2 weeks, maybe 3 weeks of not doing their routine, and they never get it back. They never can move their shoulder as good or their legs as good. And if you're asking about like supplements and all that for arthritis, there's not a lot of good evidence about any of it. Some patients believe turmeric truly helps. The evidence isn't great. The glucosamine and chondroitin, meh.
I'm just told I have arthritis in my hip. Sometimes
Yeah.
I guess I cortisone shot, but
Yeah. Exercise, there's certain therapies and exercise that can help. Cortisone can definitely help some people, and then it's the good old replacement. And I have a little plug